Our next speaker is someone whose career truly exemplifies leadership and expertise in the world of insurance and benefits. Having honed her skills at notable institutions like IMA and Blue Cross Blue Shield, she's now an executive vice president at Brown and Brown, where she's been for 13 years. Jamie is a master of aligning benefits decisions with overarching business strategies, whether that's navigating large group markets, managing intricate healthcare plans, or executing nuanced funding strategies. She has seen it all. She has witnessed firsthand the radical changes in employee benefits recently, and she's here to tell us about those trends and what pitfalls we need to watch out for. She's joined by a special guest speaker, Jennifer Kurth, and let's go ahead and welcome them to the stage.
Thank you. Thank you. Testing. Oh, it does. Crap, how do you follow something like that? That kind of an expert, well-honed skills. You guys, I hope you are in for an hour of a typical BS session with insurance, because that is what this is going to be. I'm Jamie McDonald, and as we said, thank you so much for allowing us to be here. We have a great presentation that we've gone through for months, and then we didn't pick it up until today, and reading through it, I went, what the heck are we saying that for? So I hope you guys don't mind that maybe some more of our time might be filled with honesty, off-the-cuff stories of things that we've witnessed. So fueling the future of benefits, as you can see, I am not the benefits future. I'm more the future or the benefits of past. This is the benefits of the future over here. And then we also brought another person with us in the back of the room that's drinking coffee that said, I don't want a mic anywhere near me. He truly is the future because he's in his 20s. So a couple of things. I have been in this industry for 30 years. So boy, have I seen a lot of changes. Some of them good, some of them not so much so. But we're going to go through kind of maybe some of the things that are coming up and some things that we've witnessed in the past that, 30 years ago you shook your head and said, oh my gosh, what's next? 30 years ago, family health insurance premiums were $200 a month, and we equated that to a house payment. Who in this room would love to have a $200 a month house payment or $200 a month insurance? You can't even get that crap if you're on single, right? So those are the things that I witnessed early in my career, and never did I think I'd be up here going, well, sometimes premiums are not $200, they're $2,000, and house payments are not $200, they're thousands. So it's really evolved. The only thing that didn't evolve during that time was my salary. So with that being said, middle of the road benefits person. Yeah.
My name's Jennifer Kurth, and I'm also an employee of Brown and Brown. I'm the assistant vice president. I've been with Brown and Brown for 10 years now, and before that I was in human resources for 10 years. So between those two things, I've done benefits for nearly 20 years. Interestingly enough, when I was in human resources, I liked the benefit piece, which I usually get some kind of chuckle out of that, but that is how I found my way into the insurance side. And then Jamie, you can see, is a dynamic person, so anytime you want to come work for someone like that, it's a pretty easy decision to make, and haven't looked back since. It is interesting, though, just because even within my 10 years of being a consultant on the brokerage side, it is amazing how much we've seen change over just 10 years from when I got into this side of the business. And it just keeps continuing to evolve. And unfortunately for everyone, nothing's getting easier. The days get harder, doing a lot more things, just like the business that you're in. You are probably working harder with a few less people in your offices, and the questions just come in like they're new questions, but people they question everything they know right now, and I think that it goes across a lot of industries just because of the ever-changing and the evolving regulations that surround just every aspect of being in business, it seems like, and healthcare is one of those that certainly hasn't shied away from those regulations. If anything, there's just been more and more. So as she said, we used to just have to worry about premiums and what was that going to do this year, but now it's all the regulations and everything that we have to worry about to make sure that we're keeping our clients in check and on point so that they don't have any of those fees and penalties associated with having something wrong within their elements.
Kind of like we talked about on the way up here.
She's also a storyteller. You can see that. That's why we kind of
I've got some good ones.
we balance each other out quite well.
Yes. Okay, so house cleaning items. Housekeeping, house cleaning, it doesn't really matter, right? Because you're going to raise your hand to one of these three questions. So in the benefits, how many of you deal with employee benefits? How many of you deal with things outside of employee benefits with your job? Okay, so you may not get a lot of thank yous, but we are going to tell you, thank you. My God, you have a tough job. How many of you, so when you talk about health insurance, just for our knowledge, how many of you, and there's three different answers that we're going to ask you for. How many of you are fully insured, so you pay in the premiums? How many of you are partially self-insured? How many of you don't know? And believe me, that's a right answer as well. Who really cares, right? As long as my claims are getting paid. It's interesting, though, because the funding mechanism that goes along with employee benefits sometimes can determine the different plans that you might want to offer. So you might ask us, what is our job, right? I mean, I heard I was masterful? Masterful.
She's going to use that from here.
I am totally putting that on my resume. So this is what we deal with, and this is what I imagine that you all deal with. What do your employees want? Holy crap, it didn't take me long to come up with this slide. I'm going to tell you because this is what I hear all the time. I don't want anything taken out of my paycheck, but I want lower cost. I don't want to pay when I go to the doctor. I want eye exams. I want vision. I want pet insurance. I'd like to have, seriously, you just gave me the nod on pet insurance. And it's coming back again. Yeah. It isn't. They want those things. They want those. They want disability insurance. They want to be paid when they're working and they want to be paid when they're not. They want life insurance. They want it for them. They want it for their spouses. You know, all of these things, they want choices, but they want it at a right price point, right? Which is generally zero. And so this is kind of what you guys deal with, but the flip side of that is your finance team, everything, you can have all this, but it all comes at a price point. And typically to have all of this may not align with what your executive finance team wants, which is to manage those costs. So Jennifer and I, in our careers, part of our job has been, how do you marry those together? And you give employees a robust benefit offering without breaking the bank.
And it's also a delicate dance sometimes as well that our conversations go with our finance people and our HR people, especially those that we have had long-term and really great relationships with, is what is your responsibility as an employer? Like, you're there to employ someone, and we know that there's certain core benefits that have just become the main in everyday working, and that's what people expect. And so in order for you to recruit people, you have to have certain benefits, and we all understand that. But at what point is it not your job to offer those benefits? For instance, just because it's the low-hanging fruit, pet insurance. Is that an employer's responsibility to offer that, or is it just something that they could have a resource for to give that information to their employees to say, we're not going to offer it, but here's a way that you could potentially get that on your own and still have a benefit like that. And so there's some delicate dances and conversations that always have to have because there's some employers who want to give the world, again, at a cost. What cost is that? And there's other employers who really do take that more middle of the road, like we are paying our people better from a salary perspective and offering only core benefits and trying to make sure that that's communicated to their employees with regards to what they're trying to do at their organization.
And I think too, what we've seen a lot of employers do, so I'm not sure how many of you, most of you probably were not in HR back in, dare I say, 2010, when the ACA came about. Man, have we not lived 13 years of absolute misery.
Okay, it's been 23.
23?
23.
Oh, yeah, it was. Oh, my God.
No, you're right, 13.
Oh, okay.
It feels like 50.
You know, back before healthcare reform, we saw some robust offerings, and then we had to start worrying about this silly little thing called affordability, right? Which many of you probably were already doing. But what that did was it shifted some of our employer-sponsored benefits to be more of a voluntary option. There are ways to make a benefit plan look extremely robust to where, do you guys do the employee benefit guides? That sucker can be 40 pages long if you want it to be, with all these benefits you offer, but a lot of those being voluntary to where you're introducing them, but you're not actually paying for those. Your time comes from, though sometimes I think it's the most expensive part of any coverage, is the admin time to administer some of those plans. So a couple of things that are up on this slide that are my favorites, and as you can tell, I named every one of them, so they all should be my favorites. But the two that I really, really, really like the best is down in the bottom right-hand corner. I don't understand and I'm losing it. Employee benefits has gotten complicated. Healthcare has gotten complicated. How things are covered has gotten complicated, which does not make your jobs any easier than what they were
10, 20 years.
13 years ago, not 23, 13 years ago. So there are a lot of things that drive our crazy mess, right? So you guys want to jump into some of that and more stories, because I've got stories for days, years actually. Back before healthcare reform, our team, we have people that are kind of the quarterback of a team. We call them account executives, and then we also have analysts on the team. And our analysts on the team, their job is really to analyze the claims, do projections, and as they look at claims, they're like, oh, that situation is going to has the potential to get exponential claims dollars paid, because the majority of health insurance, if you look at the premiums, the majority of those premiums are all derived from the claims utilization that your group may have. That's the majority of it. It's all usage and paying for that usage. That's the majority. There are other factors that you don't get to see, touch, and feel, and those are the things that we're also going to focus on. But prior to the C word, does anybody know what the C word is?
No, that was close though.
It
We're
was
going to talk about that in a minute.
Yeah, that was a cancer of our industry. COVID. I hate to even say the word. Prior to that C word, these are the things that we looked at in our claims. Not to say we didn't look at other things, but these were the things that were going to, or had the potential, in some isolated instances, to get catastrophic claims dollars attached to those. So hemophilia, premature babies, transplants, and congenital defects. Those were our big bad ones that, you know what, you really can't predict any of that. You can't stop it, but they happen, right? And that is what we have insurance for, correct? That's what we have insurance for. After the C word, we started noticing other things that were attributing to utilization buckets that were at an unprecedented rate compared to what we'd seen before. So our analysts started to having to look at more of the, still maybe not manageable, but not as unpredictable, right? So for the first time last year, cancer overtook musculoskeletal conditions. That was just isolated. And when I got into my career, that was really isolated. But for the first time, it's overtaken the musculoskeletal conditions. And what I thought was interesting, now there's many different kinds of cancer, right? There's a lot of different types that are out there. But there were 150 types of musculoskeletal conditions. So those were always at the top. Cancer surpassed it, and a lot of what they are kind of deriving this from is an aging population, and from the years that we were kind of hunkered down a little bit, the avoidance of care. So delayed care. People weren't going in for screenings. They couldn't go in for screenings. They couldn't go in for treatment. So those were some of the things that were really, that they were attributing the additional cost of that specific, and I hate to say that specific condition, that specific diagnostic category of cancers.
And one of the elements of that is because of the delayed care, some of the cancers then were found at a later stage, and therefore the treatment for those cancers just went from something that maybe would have been more manageable in earlier stages to something now where we're having to really treat that very aggressively, which has increased the cost of that particular diagnosis over the last 3 years or so. As we were kind of talking about this, neither one of us probably in any of our book of business have a group that doesn't have any cancer diagnosis within the top 5 to 10 claimants on those employer groups that we get claims information for. And so that is something certainly that, as I mentioned, I've seen just in the 10 years I've been on this side changing. It used to be that there would be a handful with some severe cancer diagnoses, and then there would be some groups that didn't have anything, or it might have just been a little skin cancer or something like that. But now those are in the top conditions on all of our groups.
So something else that I thought was interesting when I was, we look at claims and we look at the data and we're like, oh, what are we going to do come renewal? Because the thing that you don't want to do is strip your benefit plan so completely that it's not a benefit. I'm keeping you out of bankruptcy, right? But you're still going to pay for that. So one of the things as we were researching this, I thought this was interesting. I thought, how in the world does an aging population account for and attribute to the top cost driver? Because not sure if you can tell it from down there, but this is an aging population. So I should probably be concerned about it. Although I do love to sit out in the sun because that's my stress reliever, so I guess I'm really not that worried about it. But something I found that was interesting is the longer we live, the more errors our genes accumulate. And that's what can cause some of that cancer, is our genes are just airing out. I thought, well, that's interesting. I have never, ever heard of that in 30 years of being in this industry. I thought it was interesting that as we age, our genes start having errors. And that attributes to the aging population that can help contribute to the overall cancer diagnoses. Can you guys see that screen pretty well? Because I think this was interesting. The percentage of missed health screenings, the numbers of those, I thought that was pretty interesting as we were looking. But then on the far right-hand side, these were the other cost drivers. So if you'll humor me a bit, because I do love numbers and I love statistics. I love storytelling more, as you can tell. But the things that I thought that were very, very interesting was, I already said this before, but there were over 150 different musculoskeletal conditions. So if you work on your benefits, you've probably heard these words before: osteoarthrosis, rheumatoid arthritis, scoliosis. Those are ones that, again, looking at claims, I don't think that I've not seen some of those conditions, the drugs that go with those chronic conditions in those. Almost half of the adults in the US have some form of cardiovascular disease. Interesting statistic. Sad. Oh my gosh, it's sad, but it's interesting. And then this one is probably the one that really bothers me the most, is only 11% of the people in the US have diabetes. Only 11%, okay? So you might say, well, why is that one concerning to you? The reason it's concerning is because type 2 diabetes represents 90 to 95% of this. Years ago, I had been told that for every diabetic in my group, I had 7 pre-diabetic that didn't know it yet. That's why 11% is concerning to me. So there are some factors that really can help contribute to type 2 diabetes. Some are controlled, some are not. I'm a farm girl. I love meat and potatoes, and I love a good dessert with every meal. And that's okay, right? Everybody says everything in moderation, right? My moderation is 1 piece of cake at night, not 2. However, the things that I can control, right? My weight, my exercise. I can control those things. I don't have to have 2 pieces of cake at every meal. I can get out and exercise, which helps that. Things that I can't help is aging. So if I'm over the age of 45, I'm more likely to develop type 2 diabetes. And then there are specific ethnicity groups that are at a higher risk than other ethnicity groups. You can't change that, right? So there are a lot of contributing factors to type 2 diabetes. But what worries me about type 2 diabetics is if they're saying only 11% of the population has it, if you are in HR and you see claims data, how many of you look at the categories and you see that your diabetics are your number 3 spend? They're expensive, and that's only with 11% of the population. So that really is a worrisome thing for us when we're looking at the future. There's a lot of great drugs on the market. There really are. There's great drugs that are coming out. But all of those great drugs also come at a cost because they're new. So what do you have to add to that? Because I thought I covered that one pretty well.
You did cover diabetes really, really well. The other thing,
Near and dear to my heart, told you.
The other thing I was going to just add to the top cost drivers as far as the cancer word is that another element of that from a cost driving standpoint is some would argue that with the implementation of the ACA and preventive care being covered at 100%, that we are diagnosing things earlier on, which is wonderful for individuals as far as their health, their potential to be living longer with that diagnosis. On the flip side, again, though, if we're only wearing our financial hat, then it also costs you as an employer more to treat that diagnosis for a longer period of time. And so preventive health with the ACA, again, 13 years ago being implemented was certainly, it has some great elements to it. But again, from the financial side, there's other ways to think about that too and how that has impacted you as an employer paying for claims for a longer period of time for individuals. Again, heartstrings on an HR side, that's a great thing. From a financial side, it's just, again, that balancing act of what we're trying to do as employers.
So the bottom one on the chart on the right is mental health. And there's so much about that that it got its own slide. It didn't have to share with the other top conditions. So we're going to cover that one a little bit more. So pharmacy costs. This one, if you don't feel like you need a shower every time you talk about prescription drugs, there might be something wrong with you. Just throwing it out there.
It's a dirty word in our office.
It is dirty in our office. I told you, well, you already know my story on pharmacy and how little help anybody is. But these are interesting statistics, okay? They're really interesting. But pharmacy costs are projected to increase this year, 2023, by 9.8%. That's a lot, right? Specialty medications are projected to increase 13.5%. Non-specialty, only 3.2%. Well, the specialty ones are the ones that are really our big costing factors. A lot of people have a, back when I got into this business 30 years ago, we defined a specialty medication as anything that was $500 a month or required special handling. That's what a specialty med was. And $500 a month, have mercy on my soul, that was a lot of money. I am so ashamed to say that right now, I don't even blink at a prescription that is $500 a month. That is not expensive in our world. That's kind of the scary part about prescription drugs. There's a lot of drugs out there. They can make us live longer, right? They can make us feel younger. They can help us heal. But they have been driving a significant part of the overall healthcare spend over the last 30 years. Now, some people are going to argue, and I don't know if it's true. I'll tell you a dirty little secret. I'm married to one of those pharmaceutical reps. You can imagine our evening conversations. Guess what field he's in? Diabetes. We have some blockbuster conversations, I'll tell you that much, because we do not agree on just about anything, but that we really don't agree on. They are, there's a need, right? And if they do help us live longer with a better quality of life, and we feel better and we feel younger, yes, they're worth it. But at what cost? And there's a lot of research and development. So I don't begrudge that of anybody that's out there. But when I start looking at these costs, specialty medications, so I already said that they are projected to increase 13.5. Okay, that's one element. But the utilization is projected to increase 6.1%. That's significant, so start compiling all of that. And then when you talk about it, it makes up about 55% of our total spend in drugs. So I, every month, look at a pie chart that shows, on average, the groups that I work with, Less than 0.2% of their population are on a specialty med, and it accounts for 50 to 60% of my overall spend. It's very small, but it's very costly.
I would just say
ahead.
most of our groups right now on their specialty spend are running, it's not unusual for us to see a group that has, of all of their claims, 40% to 45% is in the specialty medication spend, which is concerning also to us because there's nothing really that we can do about specialty medications at this point in time. It's not a lifestyle change. The individual isn't choosing a drug that's the most expensive just to choose that drug. For all of the specialty drugs that are that high of a cost, there's not an alternative to that drug that helps them in the way that they're being helped by that drug. And so when we talk about specialty spend and we go into our groups and we tell them, you know, you're 40% of your premiums or your claims is specialty medication, and then we have to go, and there's nothing we can do in your plan design or anything like that in order to help that. You're going to still have that regardless of if we take the copay to your drugs up to $200 or you know, what do you want to make your employees pay? Do you want to go to a high deductible health plan? That's really not our forte, but that's always a conversation. They're only still paying a very small portion of that drug, even if they're paying a $6,000 deductible. That may be one month, but likely they're not even covering with that $6,000 deductible 1 month cost of that specialty medication on that. And so that's the hard part from a consulting standpoint to tell our groups is specialty medications going up 13.5%. You could probably see some utilization increase, and oh, by the way, you're just gonna probably have to eat those increases year over year because there's nothing we can do about specialty medication.
No, and I would tell you, that's what we would say, right? We're pretty conservative, and we're pretty HR driven. I know that there are other programs out there that they are specifically in the self-insured environment or partially self-insured that are implementing programs that exclude specialty medications. And then they put them through a prior auth where they may obtain those through Canada, Switzerland, a different country. And then they might try for patient assistance dollars. And if somebody doesn't qualify for the patient assistance dollars, then they come back and they go through the healthcare plan. Tell me that is not a burden. That is such a burden on an employee. And you know what? Is it the right way to handle expensive drugs? Is it the wrong way? I don't know that there's any right or wrong answers. Go ahead. Lower.
But it is a communication. It is having to that employee. So I think if we can offset the administrative fees and the legal costs, makes sense. I've seen it be successful in 2 or 3 ways. It is.
It's not without pain.
It isn't. Right. It's better to really put it say on the ground and say, I'm really taking my time, and that's what we're doing.
Yeah.
It can work. I've seen it work. I've seen it work very, very well. I've seen it work really
well, but to your point, you got to keep your eye on it, and you got to work on it, and there is a cost and time to do it.
That's the cost that's not factored in, and I'm glad you said that because you're looking at dollars and cents, but administrative time is worth something, and quite frankly, a lot of times it's worth a lot.
Well, because your HR person is the one that's going to get called.
Yes.
So we're the ones who's going to get called when the individual comes in and says, my drug is no longer covered. Well, you have to go through pre-authorization. You have to go through step therapy. You have to go through all these things. And you have this employee saying, no, but I need my drug right now.
Yeah.
Right? And so it's a tremendous amount of communication. But if you think that it's less than 2%, it's not a lot of people you're going to be talking to.
Yeah, that's
Right.
true.
So you have to make it relevant. It's not as if you're talking to everybody on your plan, but it's not easy.
Yeah. You know, the other thing too, how many of you've seen those coupons that are available as well? A lot of companies in both the fully insured and self-insured markets have implemented, like we call it a patient assistance, where it will use the entire value of a coupon toward the cost of that drug. So it does help both the employer, the payer, and the employee. I used to clip coupons. And there was nothing worse than taking all of your coupons up there, and if you actually looked at it, it would tell you at the bottom that it was worth 1/13 of a cent. But by gosh, it was a quarter off, and I was going to use it and hope that it was a double coupon day. That's kind of with these prescription drugs that are out there. Now, they're not worth 1/13 of a cent. They're not even worth 50 cents. A lot of those are worth $12,000 a year. But what we've seen is we've started seeing once manufacturers get wise, they start changing those programs. So I think it's Humira, had a really good coupon. And what I just saw on there not long ago was it says, not for use with commercial insurance or Medicare. So basically it was for cash payers only. So they can change those rules as they go around. That's hard to explain to an employee as well. Well, you had a coupon for the last 6 months of the year, but now you no longer have access to that. A couple of the things that we did talk about a little bit before were just some of those, the chronic conditions that we come about. And like I said, back when I got into this business, specialty medications were defined as $500 a month or required special handling. So now the definition of a specialty medication, I think this is so cool, is high-cost oral or injectable medication used to treat complex chronic conditions. That's not near as easy as $500 a month or requires special handling, is it? It could entail a lot more. The things that we have kept our eye on is we keep watching for things like, what are the next blockbuster drugs? And some of these aren't, it's not that the drug itself is expensive, but like I talked about with diabetes, when you look at it on most of my groups, diabetics are my number 3 spend if I'm looking at that therapeutic class, because insulin in and of itself might only be $2,000. But the sheer number of people I have on insulin is what's causing it to go up and the other meds that go with it. One of the things that we're watching now is the new buzzwords called gene and cell therapy. This could be world-changing, couldn't it? I mean, it's pretty incredible. So gene and cell therapy, it basically cures or treats a condition by inactivating, introducing, or replacing a modified gene in your body. Cool. My particular favorites on this one are the estimated $12 billion in spend by 2025. That's not even 2 years away, so that's a lot of money. The current cost for gene therapy drug is between $2 and $3 million. Some of that you might
For a drug.
for one treatment plan. So some of those you go, what in the world? Well, my personal favorite is hemophilia, and that is a terrible, terrible condition. A lot of times it can affect multiples in a family, and I said this on a call, and it was the most inappropriate thing in the world, but I do mean this, but maybe not in the sense I'm gonna say it. I said, my heart just bleeds for that family. Well, that's probably not the right word to use with hemophilia, right? I feel so bad. But there is, so hemophilia conditions, in any given, and I'm not sure if this is the place that we're going to talk about this or not, so it doesn't matter, we're doing it now. I've seen several, over 30 years, I've seen that condition. Not a lot, but that's one that sticks out to you, right? So on average, a non-incident year for a patient with hemophilia can be anywhere between $250,000 and $1 million, $250,000 to $1 million. That's in a non-incident year. In an incident year, which I've had a lot of incident years, it's in excess of $5 million, is what is paid for the drugs that are used, the factor VIIIs, to help with the clotting. There is a gene therapy that's coming out that could potentially, unlike the factor VIII where it's clotting the blood, it's potentially more of a, you hate to use the word cure, but they're billing it as more of a cure. It comes, the Roctavian is about $2.9 million and Hemgenix is about $3.5 million, which if you think about it at one shot, you're like, oh, holy crap, $3 million. But if it prevents incidents that are between $1 and $5 million over the course of, age whatever to age 26 when they age off your plan, that's a pretty good investment. The other one that is, some of these courses of treatments, there's a lot of gene therapy drugs that are coming down that are circulating around different cancers. So leukemia, melanoma, those are only about $500,000. So still, yeah, I say only. I'd love to have that $500,000. The one that I think, for me personally, that I am extremely excited about, not the cost doesn't excite me, but there's a drug on the market that's called Zolgensma.
I think so.
We're the ones talking about it, so it can be whichever we want. It is about $2 million, but this is a very specific drug. It's for pediatric patients that have spinal atrophy. And if it can help something like that, have mercy, that is a whole different life for that child. But it is a very small population that is going to be available for.
And again, it's just bringing it back to why are we talking about these, different elements and the cost of it? It's because, again, it's driving premium, and it's really hard. You have one person at $2 million a year. It's a lot of premium that you're having to pay back into the insurance company, or if you're self-funded, you're paying out in claims. But again, it's going to hit you in your stop loss premiums, potentially your ag premiums, depending on how the rest of your group has ran. And so these are just elements that when you really start diving into them, you can start understanding why the action is being taken on your premiums. We don't like them. We don't like that action all the time. I mean, most of the time we don't like the action, but we just, again, as in our office, in our consulting practice, we just like to try to really bring it down into reality for our groups so that they, again, you can be mad about your premiums, but you might be mad with knowledge about why you're getting your premium, and we can then help work through that and what we can do to help groups. And hopefully you have that with your consultants too, talking about what you can do versus what you can't do, and getting to a premium that you are comfortable with for the upcoming years.
So, and gene and cell therapy is kind of a new buzzword. So there are programs that are starting to come out that are saying, you know what, let's have insurance that's, because none of us have enough insurance, right? Let's have insurance that's going to cover that one-off situation so it doesn't hit your whole health plan, and we're going to put it over here in a category on its own. Those are new coverages that are going to be, that they're starting to talk about now, that we've already started seeing enter into the marketplace.
Right.
But think about your group size. And it could potentially be something that if it's going to keep a $3 million claim from hitting your claim bucket, then it might be worth exploring for those situations. So specialty medications, where we've talked a lot about being able to carve those out or being able to do it through a prior auth program. The gene and cell therapy is typically, those are going to be infusion drugs. So it's not like we can go and order it from Canada or Switzerland or Venezuela or wherever and have it shipped in. These are going to be more of an infusion type drug, and those aren't going to be available through that other means.
Yeah, those infusion type drugs run through your medical side. So when we talk about, especially on the self-funded side, we talk about the medical side and the pharmacy side. And so infusion drugs run through the medical side. So whatever programs generally that you have in place on the pharmacy side, those infusion drugs are not going through that. Again, depending on who you're working with from a PBM standpoint, some of those things can be kind of put into different buckets, but those are just really in-depth conversations that you want to be having.
So the last thing that we'll talk about, well, it's not really the last thing, but another buzzword is biosimilars. So some of you may have heard those words of biosimilars. Basically, what a biosimilar drug is it's a generic-like drug that is being introduced. So the biggest one in our marketplace is that debuted this year, and it got a column or a heading all by itself, was Humira. Everybody heard about Humira having some biosimilars. How many of you, when you hear the word generic, you think cheap, inexpensive? Isn't that what we all think? We think $4 Walmart drug list. The truth of the matter is there are some generics that are expensive. The lowest costing biosimilar on Humira that I've seen so far is about $1,800 a month. So right now you have PBMs that are out there and they're jockeying for what is best for a plan, this $1,800 a month biosimilar, or Is Humira still the best thing once we bring in, and this is why I hate drugs so much, rebates? Once we bring a rebate into the place, and I'm going to keep part of that money and I'm going to give employers in a self-insured environment may get part of those rebates. For those of you that are fully insured, at least in Kansas, which is where we're from Wichita, our fully insured carriers do not share those rebates with their employer groups. They use those to help offset other things, whether that's retention, the fluffy things you don't get to see, taste, or feel, but that's what they use rebates for. So you're like, ugh, but is it, for a plan, I really want the lowest costing drug to be what's going through there. If all things are equal, then let's go for the biosimilar, regardless of what this dirty little rebate is going to net save somebody, and maybe it's not me. Is that my clock, how long I've got left to talk? Cool, I just noticed it. They said, how will you ever talk for an hour and 15 minutes? I'm like, I have never had a problem talking for an hour and 15 minutes. So this was one of the things, and have you guys heard, I mean, I'm sure you've all heard of Humira, right? That stinking drug, since it was introduced, was accounted for $19.8 billion in US sales in 2020. Holy smokes, that's a lot of zeros. This is where I'm going to tell my story, though. So being the experienced mastermind of employee benefits that I am, I hate to see my employers. I hate to see them suffer. I hate to see what we've talked about impact them in a negative manner. And I have a small group that has about 125 employees on the plan. So you can tell, small. We have a hemophiliac patient. My hemophiliac I've had in the last couple of years, they're young. We have incident years. $5 million, $3 million, $5 million, $2 million. So I see all of this money every year. And a group of 125, now we are partially self-insured, so we shed a lot of that risk to the reinsurance carrier, but our stop-loss premiums go up every year as a result. So I got really frustrated one day because I looked at that group and I saw that, and I looked at one of Jennifer's groups and I saw a rare blood condition that was costing $600,000 a year for a medication to be taken once a month for this rare blood condition. So I got really angry. How many of you are from Kansas? Well, not very many of you. Thank your lucky stars, the rest of you. I called the insurance commissioner. And I'm like, somebody needs to do something about this. And Kansas, by gosh, if you want, well, it started at that's later. Anyway, I called the insurance commissioner, and I'm like, you know what? If you want to bring in employers in the state of Kansas and you want to offer something that's amazing, let's do a high-risk, catastrophic pool for prescription drugs, and let's take that burden off of my employers and throw that risk to the state, and let's create a pool. So I angrily dialed her, and they told me that I was not going to talk to her, but I was going to talk to somebody that had a lot of years in the industry and was going to be so helpful. And she picked up the phone, and she said, ma'am, we are here for consumer complaints. I said, well, I'm a consumer, and I'm complaining. What are we going to do about prescription drugs? She said, call the Department of Labor. Okay, let me call the Department of Labor because that's going to help. So a few months later, Jennifer and I were at a Chamber of Commerce lunch, and man, we were so lucky. They had the president of the, whatever, Senate, and the president of the House Ways and Means, and yeah, whatever they are, and they're up there and they're telling us, they said, how special it was to have them in the room because, you know, they're really movers and shakers and doing everything in Kansas to bring employers to how wonderful they were. And unbeknownst to most of us common people, that everybody thinks that change starts at Washington and it trickles its way down. However, they were there to assure us that it starts at your local legislative level and it goes up. So they made a mistake at the end of their presentation, which was very interesting.
It was good.
they said, does anybody else have something they'd like to ask? So we were,
Mind you, there's probably near 300 or 400 people
it was
in the
at least
room.
1,000. It felt like
I think we're talking to about 500 people right now, too.
I was sweating
Christy
like no
wishes.
other. Oh, I was sweating. I'm like, oh gosh. Oh, I said, Jennifer, I'm going to do it. She goes, do it. I said, I'm going to do it. She said, just do it. So I got up, and yes, I apologized first. And
Yeah, that's one of her downfalls. She apologizes, and she's this very smart person. Hopefully
I
you
thought
can
I
all
sounded
tell.
like a country
She always
bumpkin.
apologizes for asking questions. I said, quit doing that.
So I brought up, hey, not sure if you're aware of the catastrophic situation that we are in Kansas with prescription drug spend. However, we have got groups that they are spending on average 42% of their overall health spend is on prescription drugs, and we would like to see the state of Kansas start a catastrophic pool, yada, yada, yada. And I said, what can you say to that? So the first man, who was the really smart president, he said, well, I'm going to have to defer to Dan because he's the House Ways and Means. And Dan says, well, Jamie, that's a great question, but you know, really that kind of starts in Washington and trickles its way down. I'm like, are you freaking kidding me right now? You just told us that it starts here and it goes up. But when the push came to shove, it starts there and it trickles down, which really told me none of them are willing to do anything, right? So that was kind of a depressing day in our organization, at least when we got back, because at the end of the day, I think what depressed us the most was we not being in legislation, we could see what things maybe could really help at least our Kansas population, and yet we have nobody that's really willing to attack something like that. And I'm sure that there's a lot of special interest groups that are out there, but it was kind of devastating to us.
And I would imagine that the story is no different in any of the other states that are represented here too. You could probably say the same stories about your specialty spend in any states. It's not state specific by any means.
So these are all of the drugs that are losing their patent up through 2030. Some of these, you know, if you just look at the list, there's some of these that are on there that you see a lot of commercials on, right? Keytruda, Stelara, I can't wait for that one to go off. Opdiva, Ibrance, I see that on a lot. Januvia, Trulicity, oh, that Trulicity. Cosentyx, if you think about that, there's a lot of commercials that you hear behind some of those. And if you ever tried to pronounce the generic name, good luck and we'll give you a prize. Okay? Free consulting on that one because...
It's interesting on the patents though too, because some drugs, and by no means are we drug experts, again, we think it's kind of dirty, but not kind of, really dirty. But the thing about drugs when they're coming off patent is if the manufacturer comes up with another reiteration of that drug that will help another diagnosis, then it can go back, it can extend that, or it can go back as just the sole option for that new specific. And so again, then the cost of that drug can go up even though it's maybe still being prescribed for what it was originally prescribed for. Again, the cost goes up still, even if it's because of that new.
So there are those things you feel, right? You see it, you smell it, you taste it because you see it on claims reports, so you know it's true. Other things that have contributed to the increase from a $200 a month premium to excess of $2,000 are things that you have no control over. And this is probably the most frustrating, but you don't get to control the inflationary pressures. You don't get to control staffing challenges because if any of you in this room haven't faced staffing challenges, you're blessed because I think everybody has. I just wonder where they all went. Where'd that workforce go that we used to have before the C word? Provider consolidation. So, you know, in Kansas, we've seen so many providers that have consolidated. The big boys are buying out the smaller shops, and who could blame them? You know what? This is not a fun business to be in. Healthcare is not fun. It's a lot of demanding long hours, very ever-changing. The impact of delayed treatment, the pent-up demand, new treatments in technology, those are great things, right? They're great, but they're not so great when it comes to the price tag. Probably the most frustrating for us are regulatory changes. So last year I sent out on January 1st, I didn't work that day, maybe January 4th. I sent out a communication, and for 2023, there were 100 legislative changes that impacted my HR folks. 100. That's a lot. So when you think about that and then you breed that over into your benefits world, we're impacted by a lot of changes. The economic cost drivers, we talked a little bit, but adequate provider staffing, the higher patient-to-nurse ratios. I have a daughter that's a nurse. And I know that her heart is in it. She's passionate about what she does. So when you have high passion and you have high turnover and a high stressful industry, you have people that are suffering burnout a lot more. So when you're talking about higher patient-to-nurse ratios, there's a whole list of things that really start accumulating towards that. But the things that I never thought about were, nobody wants to give low quality of care, but you only have so many hands and so much time, right? So they may be getting lower quality of care. If they are getting lower quality of care, that equates to return visits to medical facilities, which then increase our costs for that. We've had, at least in Wichita, we had access issues where we have people that are waiting in an ER for 3 days, just waiting on a bed. So it just keeps compiling. And then overall, those lower things that I talked about, the low quality of care, the return visits, the access issues, really it ends up being greater out-of-pocket costs, not just to you, the employer, but also to your employees if they're being readmitted for those things as well. And then we also kind of talked about provider consolidation. And then, man, us old farts, we're just blamed on everything because we're an economic cost driver as well. So, mental health. My husband, before I got to this age, he used to sell nervous and mental drugs. If anybody's familiar or has ever heard the name Lexapro, that actually was derived from a depression medication called Celexa. So my husband, he really thought he was funny. He would take Snickers bars into the office and say depression is nothing to snicker about. That was great. I liked it when he left more Snickers at home for me. But this is everywhere, right? So if you are not depressed, if you are not feeling sad, if you are not feeling blue, by the time you look at any media that's out there, whether it's print, social, or TV, you are going to have depression. You are going to be suffering from something. So something that we've noticed in the last couple of years is such a huge influx in behavioral health claims within our employer groups. What's concerning is the number of children. So, you expect it in your employees and maybe their spouses, but our youth are being impacted by it as well. Put the damn phones down. And I'm not on a tirade for social media because I'm on it every night. I have to look and see what everybody's doing because I'm nosy like that. But for our kids, I think that they are so impressionable. It just breaks my heart. So this is everything that, and these are real covers. These aren't covers that I designed by any means. But the significant increase in mental health, I feel like it's real, but I also feel like when I go to the doctor's office, they're starting to ask me questions they never used to ask me, right? Yeah, have you felt sad lately? Heck yeah, have you? I wake up every morning sad when I try to get out of bed because I am not 25 again.
It is interesting though, because I do think that there's some shifts. Like yesterday I was, just again, we all have our moments, and even I went home, and again, I have a great person I work for, so vented to her. But I go home, and my daughter, who's 13, my youngest, says, "Mom, what's wrong?" And I said, "Oh, I'm just having a day, but we'll be better tomorrow," And so we all have those days, and so depending on, like she said, when you go into what day do you go into the doctor? I don't know, what do you have going on? I'm at the doctor, so I'm probably not feeling the best anyway, unless it's just my preventive. And even then, you usually have something going on. So there is this element of what is being, and what we don't see on the back end is how does that answer get pushed through the medical system? Does it come, if I say I'm feeling blue that day that I'm at the doctor, does that automatically get pushed through on the mental health side, or is that just because they're going to then assess it more to see if there really is an issue, and we don't see that backside of it? But it is concerning, as she mentioned, with the kids. I mean, I have 3 kids, 2 kids now under the age of 18. One of them just turned 18. And so you do worry. You do worry about that. And with everything going on, all of this stuff, who read 17 when we were young, and you weren't quite in your age, but you're more not my age. I mean, we read stuff, and we read it then on a magazine, and we wanted to do the things that were in 17 or whatever Vogue. And so now when it's just in your face all the time, we can understand why the kiddos feel the way they do sometimes.
Okay, so I just noticed something because I thought this was a really cool slide, but as you were talking, I really paid attention. Does anybody notice that the 3 left ones are all about Britney Spears? Who in this room had a free Britney
She
t-shirt?
probably was reading 17 and was impressionable.
I had a
during
free
that
Britney
time.
t-shirt, and I'm just gonna throw out that if you follow her on Instagram, I'm thinking the conservatorship might have been a good thing for her. Just throwing it out there. So this is, see how my mind works? Isn't it terrible? So this is the one thing I am gonna give everybody. Stress is a basic cause of illness. Because have you guys ever thought about, and this was funny, so the future of benefits sitting in the back room without a microphone in his hand, we are going through this as we're preparing at the yard house, and he's like, oh my gosh, this is true. And we're looking at everything. Stress, for me, I'm like, stress causes me headache, man, I love going and getting a massage, especially when I'm stressed out, and she tries to break these bricks that I call shoulders. You're not getting through those knots, honey, not unless we're here for 120 minutes. Chest pain. Chest pain used to be the #1 thing seen in an emergency room. People went in thinking they're a heart attack. It was an anxiety attack. They mirror each other. Fatigue. Stress makes me darn tired. Upset stomach, mine come like flu-like symptoms. But from there, it does your mood. You become anxious, you're restless, you're overwhelmed, you're not motivated. You become depressed with it, and then the behavior from that is, I'll just go ahead and say out there, I've done all of those. I mean, drugs, they're only the legal source, but overeating, you might drink, tobacco, 16, 17, 20 years maybe now I haven't been a smoker. I still miss that sucker first thing in the morning. Thank you. I still miss it first thing in the morning with a cup of coffee. Anger, I get mad. When I'm stressed out, I bite people's heads off, and they don't have to do anything but just look at me. And I sometimes just hope somebody does. Dylan,
It's a stress relief.
True, isn't it?
It then becomes a stress relief mechanism as
It's
well.
totally stress relief for me. And then no exercise. Who wants to exercise when you're feeling kind of crappy like that? But then it's this vicious circle of things. So there truly is a link to your overall mental health and your physical health. And stress is that common denominator that can link all of that together. So this is depressing because you know why? I have 18 minutes left and I like to leave everything on a depressing note. Recent surveys suggest 76% of US workers reported at least one symptom of a mental health condition. So you guys already saw some of those symptoms. Those could also be linked to other things. But 84% of the survey said that their workplace conditions had contributed to at least one mental health challenge. Well, all I can say is they're not working where I do because that links to all of my mental health challenges. True story. I had 17 minutes left. This is a good story. So I was doing an employee benefit fair last year because I still like to do things like that. You know, you have candy at your table, you talk to people. And I was talking to another person that was there. She is the CEO of an employee assistance program. You guys are gonna love this because I just thought about what industry you're in. She says to me, I asked her, I said, boy, I said, how are you guys faring? You know, it's 2022. This was November. It was November 1st because I had to get candy to take to the benefit fair. Our big grocery store in Wichita is Dillon's. Damn them. 75% off all the leftover Halloween candy. I was trying to figure out why all these people had these carts full of candy. I'm like, well, aren't they just greedy? Then I saw 75% off. I left with an entire cart full of candy. I still have candy left over from last year. But I'm talking to her at this employee benefits fair, and I said, how are you faring? I said, we all know coming out of the C word that 2021 was going to be a little bit rocky. And she goes, oh, geez, Jamie, she said that didn't prepare us at all for 2022. She said, I have had more employer referrals than I've had in my entire career. And she said, I'll give you an example. I have 2 different clients that are in the banking industry. She said they had an employee referral because in one of the situations, they had 2 of their tellers that got into a physical altercation in the lobby in front of customers. I'm like, well, hell, what bank was that at? I didn't ask that question. And she said the second one, they had a bank teller and a patron that got into a physical altercation in the lobby. That is not something I think about in your industry. I think of professionalism. I think of a safer environment and hope that nobody's trying to hold you up anymore. That's what comes to my mind, not 2 employees getting into an altercation. That just really, I was just shocked by that, but it told me nobody's immune to this, right? 81% of workers reported that they will be looking for workplaces that support mental health in the future. I have everybody asking about employee assistance programs. What are some of the better programs that we can do? We have had several of our groups last year that implemented $0 behavioral health copay. You're not giving up that much. You're really not. And if it keeps an employee going to see somebody, to talk about in a safe environment, the biggest problem with that is providers. We do not have it. We are in a severe provider shortage of our mental health counselors in our society. So
the other thing I will add to that, it's also why we've also seen an increase of employers who have wanted just to explore at least what they can do from a wellness standpoint, because again, on the other sides, we were showing how exercise and helping with some of those other lifestyle choices can help the overall stress and everything of that employee. So at first, when I got into this, it was kind of like, I don't understand why the employer's thinking, again, back to what does the employer need to provide? Why should an employer be providing those type of situations? But as I've aged in this particular industry, now with these mental health stats, you can kind of see where that does help the medical spend as well when we bring it back around to the premium part of it and why that is important for employers now to be exploring too.
Didn't you want to say when you grew up in this industry? Because you've grown a lot, grown up in this industry. So a lot of employers say, what can we do, right? Virtual care. Prior to the C word, nobody thought about calling the doctor on the telephone, unless you're from a small town, then you might. But we've seen a lot of integrated virtual care where it's not just your general medical conditions. They're starting to bring chronic condition management into that, but specifically, they're bringing in a behavioral health component as well. A lot of my groups have all of that set up at a $0 copay to the employees, and this was one good thing that came out of last year. Even with a qualified high deductible health plan, you can still have a $0 copay on some of that. Preventive care and cancer screenings, this is another thing that you want to encourage your employees anyway to get their preventive exam done, right? Get early detection, whatever it may be. But with the delayed screenings and what we've seen from the delayed of treatment, you just want to really be able to focus and really steer your employees into the warm, fuzzy feeling of, even if we don't have a wellness program, we care. Your preventive health is 100%. If you're not grandfathered, go and get it done.
I was just going to say something on the integrated virtual care with the EAPs. If you have an EAP in place, I would make sure that you're, if you don't already know, to see if they have the text therapy option available, because again, bringing it back around to our teenagers and our younger children who are having those issues, we said stay off of your phones or whatever, which we could all take that advice, but the reality is they're on their phones, and so that age group may be more susceptible to having some kind of therapy if it's on a device that they're comfortable with. So a lot of EAP programs are implementing that, but there's still plenty of them out there that they just have the traditional call-in kind of therapy situation or that in the moment. And so if that's something that you're seeing in your medical spend, you may just make sure that you're looking at those other avenues for therapy as well.
And really promote, right? You've got to keep talking about it. Employee assistance programs specifically, if an employee doesn't pay for the benefit, sometimes they don't realize they have it. So it's promote. That's one thing you can over-promote. Centers of excellence is another great, those are where typically insurance companies are going to have the best discounts negotiated for some of those higher costing treatments, transplants, things like that. And then value-based designs, we're starting to see this come back around. If you've been in anywhere, now I can't fit into anything in my closet from 30 years ago. I can't even fit into anything in my closet from a couple years ago, whatever, but value-based designs are coming back around with a different name. I've seen it come up twice already in my 30-year career. So some of those are getting more of a narrow networks, trying to really force the discount envelopes. We've seen groups in Kansas, we went away from the HMO model. So we don't really have a lot of HMOs, don't really need a PCP. We've kind of seen the downside of that though, because our kids that are entering the workforce, once they get done in the pediatrician stage, they don't really know where to go. So they're not getting a relationship with a physician until they're sick and have to go to an urgent care or an emergency room. So value-based designs are coming back around again. On pharmacy, we've already kind of talked a little bit about excess risk programs. Those are kind of what, and you didn't even say your name. I at least had to tell mine. Virginia. So Virginia was talking a little bit about some of the carve-out strategies that they have been able to implement in theirs. And it's not so much carve-out, it's really more of a prior authorization program to see if any of those other things work before it comes back to the health plan to achieve savings. The excess risk programs that we talked about, a lot of insurance companies are starting to look at, do you want to implement yet another insurance program to take out the gene cell and the T-cell therapies, things like that.
The part that you have to be open to on those excess risk programs, these extra little insurance programs, is you have to generally be willing to buy that at a time where you don't have a condition going on, because generally you're going to be excluded, or at least that one condition will be excluded if you have someone who's currently going through treatment. So you have to be willing to buy that, knowing that in the future there's a likelihood you're going to have something come on your plan that this will be very helpful for. And that's a hard pill to swallow sometimes. Pharmacy.
Pharmacy,
But,
that was good.
Yeah, that was.
Wow, for you.
And
really
so paying that extra money and then in hopes that it will help you in the future.
Hopes that you don't ever have to use it.
Yeah, yeah.
You know, something that we are big fans on too is advocacy programs. So we've started implementing a lot of advocacy programs where employees are able to call these patient advocates and they are able to help navigate this complicated world of healthcare. Not insurance, but healthcare. Healthcare is really, really tough. My husband, who you guys are gonna wonder why I'm still married, because I use him in a lot of stories. Some days I still wonder it too, but he had back surgery. 2021.
Yep.
2021, he had back surgery. And at the time, does anybody in this room remember when they made it mandatory that an employer had to provide COBRA if anybody left their employer? You had to pay for it for so long if they didn't have other coverage available. Well, we had other coverage available, and we were covered on our program. His employer went ahead and set us up with COBRA as well. Well, sucks to be you. Didn't need to do that. So we were double covered when my husband went and had surgery. Just so happens we were double covered through the same insurance company. So he had his surgery in August of 2021, and the bills started just piling in. You can imagine back surgery. It was $69,000 just for the facility. And I'm in this business. I kept calling. I'm matching up every claim to every EOB. I would call providers. You need to file it with this insurance carrier first. I mean, it was a full-time job navigating the bills and the insurance. And my husband at one point told me, oh, well, you don't have to. I called our hospital that he had it done, and they told me there was zero balance due. Lies. I knew it was. Knew it was. All of a sudden, we start getting a notice that they're going to turn us over to collections. So fast forward to July of 2022, so we're almost a year in. I have been dealing with this stuff for a year, and I am calling. I'm trying to get something, and I happened to be out to lunch with a person I've known for a long time, and I was telling her, we're talking about our families. I told her about James, and she said, Well, that hospital, for those of you in Kansas, it was Via Christi. Well, Via Christi just got a new president at St. Francis Hospital. It was in the Business Journal. So when she got back to her office, she sends me the lady's name and her picture. So I call, because I'd already called and nobody could help me, I call and ask for her directly. I got her executive assistant. Weird. It was so weird. Within the week, my husband's claim was paid because they finally filed it with our insurance carrier that was primary, even though our insurance carrier that was primary, they would no longer talk to on the phone. They said, we're no longer going to talk to you. They wouldn't help me. And here this poor woman had her picture in the Wichita Business Journal, and I got her number and got her executive assistant that within a week, that claim was paid 100% because they were going to turn us over to collections for $70,000 on a claim that they would not file appropriately. That is somebody that's been in the industry for 30 years. I can't even imagine your employees that they have their own job functions to do. How are they supposed to know to navigate all this? Now, $70,000 you might question, but if it's a $70 invoice or a $50 invoice or a $25 invoice, might they just pay it to make it go away and it's really not something that they owed? That's the part that bothers me. So we've put a lot of advocacy programs in place in the last year to help people navigate all of that. Lean on your consultant. So most of you aren't here. You may work with a Brown and Brown team and wherever you're from. If you do, tell them they're not near as fun as we are, but don't tell them that we just went off the cuff with this presentation. We won't see you next year. Brown and Brown's a little bit of a large company that might frown on that. That's why I told you, I couldn't put the stories in writing for crying out loud. But, you know, there's a lot of different ways that you can evaluate your programs. Look at the data. Don't put your money into programs that aren't going to net you what you want them to or not going to achieve the savings. Don't put in benefit plan designs that aren't going to net the results that you want. Employees want choice, right? But do they? Do they really want choice, or do they want you to pick one plan and tell them this is what we're going to insure, this is what we offer for our health insurance? I don't know. I've watched the roller coaster of I want choice, ooh, which one should I take? And I get that question a lot. I don't know your situation. But lean on them. Benchmarks. There are benchmarks out there everywhere. We tell our clients, don't rely on benchmarks. They're great to know what your competitors are doing, but don't set your benefit plans according to benchmark, because benchmarks are set by insurance companies. So don't follow those. Know what they're doing, but you don't need to follow those.
And they're set by insurance companies because most groups in an area are fully insured, and the insurance company is the ones who are setting the benefit design. So by just mere choice of what you have, you're going to choose one of the designs that the insurance company has given you. And so therefore, even though they're not setting benchmarking, you have to choose their plans. So that's why we say that they are setting those benchmarks, and they're not going to put out a plan that they don't want to offer on a fully insured plan.
The other thing that I think is extremely important, and you guys already know this, but customize your benefit communication tools. So you saw cutting edge, new fueling the place of workforce, and I come in with a paper copy of what I'm supposed to read, right? Jennifer would probably prefer to read it off of an iPad, and Dylan probably prefer to read it off of his phone. But you have a lot of different generations that are in your workforce, and all of those respond differently to different ways. So you need to find out and make sure that your communications are structured as such so that you are touching all of those generational workforces. But I think that this was kind of interesting, you know, learning, gaining insight, educating, integrating, getting a strategy in place of what you want to do, knowing your strategy is a 3-year blueprint that is going to need to be tweaked every year because our situations might change or our climate might change. And then this was the different, oh gosh, they say there's 4 generations, and I'm guessing I'm a baby boomer. Am I? I'm not quite to Medicare age, but I'm getting darn close, and I'm so thankful. No, not really. But there's the 4 generations that are in your workforce. I am not a baby boomer. I am a Gen X. But everybody needs different things. Medicare, you think health insurance is confusing? try to go down Medicare pathway. That is even more confusing. So there's a lot of different generational needs that you may have to deal with in your workplace. With that, I have 1 minute, 41 seconds. What kind of questions do we have? Dylan, I told you I can talk for 1 hour and 15, and I have no problem. I talk to myself for 1 hour and 15 at home all the time. Sometimes I answer myself.
Every morning when I'm getting ready, I have a whole full conversation.
Yes.
Hi, Michelle. Do you have real data? Because I know you seem to be the straight shooter on that. Do wellness programs actually reduce costs?
You want me to tell you the truth, don't you?
Yes.
You know I love this one.
I love this question too. And I can't wait to be honest. My name is Jennifer Kurth. No.
Go ahead. You.
Okay.
I'm fairly certain we lost a client in a prospect meeting one time because of my honest answer to her.
It was, in our opinion, and do we have the data to support it, to gain a real ROI on a wellness program is extremely difficult because how do you put a dollar value on a claim that does not happen? I personally have seen in my career, specifically probably in the last 20 years, not my first 10, where a lot of good money was spent on wellness programs after a not so great cause. So they were promoting the things that some employees are going to take advantage of, some are not. The only real way to get a wellness program to return dollars on your investment is if you are willing to make employees put skin in the game and have an outcomes-based program. That means you have X number of years, and here's our 5 criteria, and if you don't hit 3 of the 5, you're going to pay a higher premium for it. If you are wanting to implement,
Criteria such as your BMI needs to be in
your BMI, your
range
tobacco
that's-
status, your blood pressure, your cholesterol level. I don't remember what that 5th one
I
is.
can never remember it.
But those were all low-hanging fruit that we got because you can see my BMI, you can smell me if I'm smoking.
So that's when the outcomes base comes in, and we would argue that you're going to need to be willing to invest at least 7 to 10 years of stats that says that you're probably not going to see an ROI on it until you get to year 7 to 10, depending on your specific culture. And we have data in our things that would support that.
So to summarize my answer, our answer, no, they don't work. Unless you are willing to put skin in the game. And maybe some of you are more courageous than the employers I work with. I don't have a single employer that once I say, are you willing to go to outcomes-based wellness in order to get the ROI that you're looking for? They're like, no. But I have employers that do it because culturally it is the right fit for their employees to think that there is, and not think, but to feel that there's a cultural reason to have wellness.
Yeah, they're making an investment in their employees and trying to get them healthier by choice, which generally works better over the long run anyway. If someone's choosing to do something, it's going to be sustainable for them as opposed to being forced to doing something where you're generally going to be in that element for a short period of time, whatever that time period is that you have to meet the criteria, and then you're back to your old habits. I mean, that's just anything in life.
So before the Stay Fresh and all these great little break room, you guys have seen that. Oh, geez, those look great, don't they? Back before all that. I had a client that I worked with, and he was huge on wellness. This is before wellness was a word. He charged, the vending machine was based on the fat grams. So if you want that burrito, that's great. The burrito was X number of fat. That burrito ended up costing people $8 coming out of the vending machine. Byron, he was a pioneer, so you can't do that anymore because you might hurt somebody's feelings. But back in the day, he charged that their vending machine was based on the fat grams of the item that you purchased. And I thought, you know what? What a way to make employees recognize the fat grams, because that was way before they had the calories on the menus. Yes, any others, guys, please?
average increase in health premiums have you seen in your area?
God, I love that question. And I could tell you the honest truth is it depends, but our average, we have a couple of outliers, and those outliers deserved, based on utilization, you hate to say deserved, but they merited a big increase. But if we remove that, so far we have seen mid to high single digits in our area. 32%, and they definitely deserved, they merited it.
Okay, I'm in Virginia, and I had a 24% increase.
For 2024,
Yeah.
how big is your group? I hate to get into it.
77 people.
Oh, gosh,
Yep,
that's hard.
dadgummit. See, that hurts.
And we just had an acquisition, we're gonna have almost 698, and I just, have to find out, we have like 8 different real, true time situations. So we're gonna add that on top of it. I don't even want to see this following year.
It's you know, what can you sustain? You know, you can't sustain that year after year. You just can't. That is, I will say in our area, so we're in Kansas City, Missouri. Kansas City, Kansas, outside of 2 counties is really a very heavily predominant, fully insured marketplace, with Blue Cross Blue Shield being the big bad umbrella. You do?
Yeah.
You know what? They're the
lot of
carrier that we love to hate. And their underwriting methodology has always, and that's who I got my start with, it's always been fairly sound. Doesn't mean they're my best friends. I hate what they're doing on some things. But we don't have a lot of options in a fully insured marketplace. So outside of Blue Cross, where we're from, your 2 reputables are Aetna and United Healthcare. So some of our employers are kind of stuck.
Couldn't even get quoted from anyone else to even try.
That's what we're at. We're here in
Zero
Kansas
quote.
City.
You're Kansas City?
We have 48 employees, and we have a couple, we have one that's a spouse and one that's an employee that has some long-term conditions, and we have an aging population at our credit union, so we can't even get quoted by anybody else.
You know, that is such, I'm sure a lot of this that we were saying up there resonates, because it's unprecedented what we see in groups. And it breaks my heart to say a drug of $500 doesn't make me blink. I have seen generics that are $150. That one generic for the Humira, like I said, $1,800. That's a lot better than the alternative at $7,000. But you know, when you're a smaller group, it doesn't take very many of those situations to just really plummet you. Now, the good thing about some of that is you're not very credible for your own utilization, because one of those catastrophic conditions throws it out. But 20% increases year after year are nothing to sneeze at. Yes?
Did you mention earlier in your presentation, you don't do a lot of high deductible health plans?
So we didn't mention that, but the truth be told, we don't. We're not opposed to high deductible health plans, as long as you're doing them for the right reason. And the right reason is not to try and get the lowest premium on the board, and then all of your employees that cannot afford a high deductible are on that option, because that's what they can afford. If you are in a business and you have wage earners that need a tax shelter, and they truly do understand that that can be used for post-retirement needs, and HSA can, that is a great reason to do it. So we actually, we had a dual option, took a long time to get there, and then
We being Brown and Brown.
Brown and Brown.
who we work for.
yeah, we got a dual option, and they contributed to an HSA for us. And then it went away, and then this year they brought it back. And we don't have any employer dollars toward the HSA, but we do have people that were utilizing it. Myself, the reason that I like a qualified high deductible health plan is because I wanted to use my HSA dollars for post-retirement, because I can pay for Medicare premiums, I can pay for supplement premiums, and my employer doesn't give me a retirement plan. So I thought, well, that's a good way for me to use those dollars. So
The other element of it from just the financial part of it is if you're going to offer one, make sure you're offering it at the right price to your employees. We often say don't put it on sale just to push people there, because again, a lot of your employees are in a situation where they're going to take the lowest costing premium option out of their paycheck, regardless of if they understand what it's going to cost them when they actually go to get services, and then they can't afford the services, and you're not putting them in a bad situation. They've made a choice that they may not have completely understood, and now it's putting them in a bad situation. So don't put your high deductible on sale from a contribution standpoint just to push people to that. And again, there's a whole other, we could do another hour and a half from a financial,
I'd love to.
fiscal piece of it on why you don't want to do that in order to help stabilize your plan.
Yep. And that's, I'm sorry, that's one thing too, that with the high deductible health plans, again, I think they can be tremendous. There's some communication that comes with it to employees. Where we are at, we're just not seeing a significant dollar difference between a qualified high deductible
Right.
health plan and a typical PPO plan is what I'm going to call them, because ultimately at the end of the day, your maximum out-of-pockets, the MOOPs,
Yep.
are the same regardless. So, you know, if insurance companies, if they want to get $5 million out of you because that's what it's going to take to cover the claims, in all reality, plan design has very little to do with the overall cost of healthcare, because whether you have $1,500 out of pocket or $5,000 out of pocket on a $250,000 claim, it really doesn't make any difference.
Yeah, we did the high deductible, trying to be more term, we pay $1,000, the next $1,000 up to $1,000, and it's actually costs us more money. After this increase, it's almost $160,000 increase, so based on that, if they all take the high deductible, it costs us more. But it's more maternal because the out-of-pocket max is only $3,000, so once they beat that, all the better.
They're done. I have one employer last year that they contribute 100% of the deductible, and they have a $3,000 single, $6,000 family. They contribute 100% of the deductible in an HSA. Half of it they put in January 1st, and then the other half July 1. Believe it or not, I'm still not at 50-50 on my employee population. 50% of my employees are still on the PPO. Yes, I'm sorry.
I had a question in regards to, and maybe this is a little bit of guidance without giving advice per se. So I have employees on two different coasts. So I have LA and I have DC. I have remote workers in South Dakota. I've got remote workers in Virginia, Maryland. So I'm in about 6 or 7 different states.
God bless you.
Yes, thank you. So we're the product of a merger of 2 different banks on 2 different coasts, and my California people had Kaiser for years. So they are extremely loyal to Kaiser, and getting them to talk about anything else other than Kaiser is like pulling teeth.
Yep.
The rest of my organization is on Cigna. The issue that we're having is we just completed our open enrollment September 1. Most companies won't quote us because we won't let go of Kaiser, because California won't let Kaiser go. So my question to you in that event is, what should we do? Because my Kaiser people saw about a 9 to 10% cost increase over this year. My Cigna people saw a 35% increase.
Yeah.
So we're trying to distribute that cost evenly. The Kaiser people are saying, well, ours didn't go up, so where's all of our premiums getting so high for? So like, what do you suggest we do as far as trying to potentially bring everybody under one umbrella with the same type of service that my LA people feel like they can only get from Kaiser?
You know, Kaiser is a tough one because it truly is the only thing they can get from Kaiser, because Kaiser owns the doctors, they own the facilities, and we don't have a lot of markets anymore that are physician-owned or where Kaiser, the insurance company, actually owns the physicians. When you went out to look at other bids, did you ask for a quote for everybody outside of California, that you weren't going to do a slice offering?
Well, the way our brokers set it up was that we had to disclose how many people we had on Kaiser and how many people we had on Cigna and how many people, if they were to quote us, would actually be eligible. So we had one time they wouldn't even quote us because most companies won't split quote.
Yep.
So we had to say we're bringing all of our employees, knowing chances are we probably wouldn't.
Yeah, so I have a group, they're about 1,100 is, we deal in groups that are all sizes. So I'd say our smallest group is maybe, I think they've
Our
got 15.
smallest
Oh,
is
that's
two.
2. She's got the record, it's 2. We have a small group of 2 people,
It was a favor group.
2 people, and they're sweet.
You know, they appreciate the.
Yeah, up
little
to a
bit of
couple
weekend.
of thousand. My 1,100 life group, I have a segment in California, and every 2 years they ask me to get a Kaiser quote. The rest of the group, because they're private equity, so they have a lot of different portfolio, the rest of the group is covered on Blue Cross Blue Shield of Kansas in a different financial arrangement. But when I went out and got quotes, because they've got people everywhere, every state, but I did not, when I went to Kaiser this year and got a quote for them, I told them it's not a slice offering. So my people in California do not have a choice. They're not going to be covered on anything but the Blue Cross Blue Shield. Everywhere else is Blue Cross. Those people will have to go to Kaiser. The one thing Kaiser did ask me is if I wanted their traditional Kaiser plan and a Kaiser PPO that would offer more of the PPO arrangement, of the benefits like what they were used to today. Because right now those people in California are covered on my group. We don't offer Kaiser. How, if you don't mind me asking, your Kaiser group, of your total population, about what % are they?
So we've got 100 employees. We've probably got about 40% of the total population that's on Kaiser. But of my California employees, that's probably 75 to 80%.
Okay.
Because the California employees have the option. None of my other employees do.
So that's why.
Yep. If you would do me a favor, if you would give one of these 2 ladies your information, let me do a couple, what is your corporate office? Where are you domiciled at?
We have 2, one in LA and one in DC, but I'm in LA.
You're in LA?
Yes.
If you don't mind, let me call one of our business associates, Mark, and just ask him his opinion on something like that out there, because he is actually on the California coast, and then I'll email you if that's okay.
Perfect.
Is that all right? Oh, they just told me I'm done. Dadgummit, I could talk for more time. I'm not hoarse yet. You guys have been wonderful. Thank you. Thank you so much.